Good morning, everyone. Sorry, little bit late today. Anyway, Dr. Shino will talk to us today about the association between parenchymal enhancement of the contralateral breast in dynamic contrast enhanced MRI and outcome of patients with unilateral invasive breast cancer. It's an interesting subject.
Thank you. Good morning. This was published in 5th of September 2015 in the RSNA journal. The purpose of this is to retrospectively investigate whether the parenchymal enhancement in the dynamic contrast material enhanced magnetic resonance imaging of the contralateral breast in patients with unilateral invasive breast cancer is associated with therapy outcome. Introduction. The breast cancer is no longer considered to be the single disease, but it's categorized into three different subtypes according to the immunohistochemistry. We have estrogen receptor positive, human epidermal growth factor receptor, HER2 negative, that's independent of the progesterone receptor status, or HER2 positive, independent of estrogen receptor and progesterone receptor status. And you have also triple negative, that's estrogen receptor negative, progesterone receptor negative, and HER2 negative.
Three receptors, estrogen receptors, اللي هي دائما immunohistochemistry, it will affect the whole management. Okay.
So different treatment plans are advised for different immunohistochemistry subtypes, including endocrine therapy for those estrogen receptor positive, HER2 negative tumors, anti-HER2 therapy for HER2 positive tumor, cytotoxic HER2, okay. And cytotoxic therapy for estrogen receptor positive, HER2 negative tumor, HER2 positive tumor, and triple negative tumors. Nevertheless, the variation still exists in the treatment outcome within the breast cancer subtypes. This may be due to the de novo and acquired resistance to endocrine therapy. So additional biomarkers for obtaining more patient-specific predictions for treatment outcomes are desirable.
So sometimes you might find a case with breast cancer and she's responding well to treatment, everything is okay, and suddenly she comes with liver tumors, liver metastasis. There might be some change some mutation in the receptors. So you need to do another biopsy for the metastasis and another immunohistochemistry to see what's going on. What's the mutation happening?
Imaging techniques have been used to analyze the risk factors of the microenvironment in the vivo prior to the treatment. A well-established risk factors are mammographic breast density. So parenchymal density is related to the risk of developing breast cancer. It's not related to the survival of women with the breast cancer. Not related to the survival, but increased risk of CA.
Nice.
Dynamic contrast material enhanced magnetic resonance imaging of the breast allow assessment of functional behavior of the tumor and the parenchymal. So giving a typical symmetry between the left and right breast, we have found that the parenchyma of the healthy contralateral breast is comparable to that of the ipsilateral breast before tumorigenesis. Material and methods. After obtaining approval of institutional review board and patients' written informed consent, women with unilateral invasive breast cancers underwent dynamic contrast enhanced MRI between 2000 and 2008. The contralateral parenchyma was segmented automatically, in which the mean of the top 10% late enhancement was calculated. Cox regression was used to test association between the parenchymal enhancement, patient with tumor characteristic, and overall survival and invasive disease-free survival. Subset analyses were performed and stratified according to the immunohistochemical subtypes and types of the adjuvant treatment received. MRI imaging were acquired by using the 1.5 Tesla imaging unit with a dedicated double breast array coil and enhanced coronal fast low angle shoot 3-dimension T1 weighted image.
Fast low angle shot. Flash.
T1 weighted image was acquired. A bolus dose of 14 ml of gadolinium-based contrast material was administered at 3 ml per second by using a power injector, followed by bolus injection of 30 ml of saline solution. Later, subsequently, 4 consecutive contrast-enhanced series were acquired. The image parameter were acquisition time of 90 seconds, repetition time millisecond per echo time of 8.1 per 4, flip angle of 20, focal size of 1.35 by 1.35 by 1.35 millim, and field of view of 310 millim. The processing of the MR imaging consists of the 2 main steps. First, parenchymal segmentation and calculation of enhancement. Processing was implemented by using of the inside segmentations and registration. Parenchymal segmentation, parenchyma on the MR imaging was fully automatically segmented in 3 dimensions. So they calculate that the number of the voxels in the parenchymal mask divided by the number of the voxel in the breast mask was calculated automatically in 3 dimensions and was defined as the percentage of the dense tissue. And they measure this, yani percentage of the dense tissue. Calculation of the enhancement. Each voxel is in the parenchyma at the breast MRI imaging typically shows a continuous increase in the signal intensity over time after contrast material injection. This is T1 weighted over the case with a breast invasive carcinoma without fat suppression.
Okay. So
this pre-contrast.
No, this is pre-contrast.
This is they say that putting mask.
Putting mask. What does it mean putting mask? Before contrast or after contrast? The same image, okay, of the same patient in the same position at the same time. Before and after contrast. So you subtract one from the other. شيبقى عندك بس الكونتراست يضل. هو هذا الماسك. مثل DSA Digital Subtraction and Geography. بس تطرح واحد من الثاني قبل وبعد. اوكي؟ يعني اني قاعد هيك بعدين اني قاعد هيك ولازم موبايل. اذا تطرح الصورتين يضل بس الموبايل. اوكي؟ فهو هذا الماسك
يعني هذا هذا.
Okay, so when it's subtracted one from the other, remaining is the mask. Highlights the different parts. So this is the enhancing part.
This is the late enhancement. Show the the more dense
parts.
أو pointer هي كان enhancement زيادة. Survival analysis, and even in 51 of 531 patients, 10% of the overall survival, 73 of 531 patients, equal to 40% for the invasive disease-free survival, 480 of 531 patients, it's equal to 90%, were censored for overall survival, and 458, 86% were censored for invasive disease-free survival.
Result. How do they calculate it? Which is يعني شو نقول شغلات calculations more than interest us. What result? صار
Result in the 531 patient with unilateral invasive breast cancer, the 10% most enhancing parts of the parenchyma in the contralateral breast was found to be associated with long-term patient outcome, particularly in patients with estrogen receptor positive, HER2 negative breast cancer. Patients with lower enhancement value had less favorable therapy outcome than those with higher enhancement value.
هاي الثلاث أسطر الأخيرة هي أهم شيء بالموضوع كله. إنه the patients enhancement مال يعني of the other breast, if it is less enhancement means bad prognosis or worse prognosis. If it enhances more means better prognosis. هذا الشيء بالحكي كله. They don't know why. They are just doing an experiment and seeing what's the result. بعدين we should know why for further analysis.
So contralateral breast parenchyma enhancement has the potential to serve as the biomarker to guide therapy selection in patients with the estrogen receptor positive HER2 negative breast cancer.
It's amazing. You have a patient with right breast invasive carcinoma. You do MRI, you see increase enhancement بالleft breast اللي هو normal and you say this has a favorable prognosis. This is very big يعني it's not مو لعبة يعني حاجة كبيرة ترى. يعني من other breast normal you can predict the prognosis.
The prognosis of the patient. In conclusion, results suggest that the parenchymal enhancement in the contralateral breast of the patients with the invasive unilateral breast cancer is significantly associated with long-term outcome, particularly in patients with estrogen receptor positive human epidermal growth factor receptor 2, that's HER2, negative breast cancer. Low value of the mean top 10% enhancement of the parenchyma shows potential as a predictive biomarker for the relatively poor outcome in patients who undergo endocrine therapy. These results should, however, be validated in a larger study or longer study.
Need more patients,
Yes.
more time, more analysis. But anyway, يعني the result is يعني very interesting. You know, you have someone with right breast cancer, you do MRI, you tell them this is a good prognosis, a bad prognosis, based on the normal breast. It's not that. Okay. So. Now, Dr. Shirin will present signs, لا مو signs, sorry, differential diagnosis.
Good morning, everyone. Today I would like to talk about one of the common benign cartilage tumor, which is enchondroma. Enchondroma, or they are also known as chondromas, are benign tumor composed of mature hyaline cartilage. They generally have limited growth potential and are not locally aggressive. When they occur in the intramedullary canal of the bone, they are referred to as enchondroma. Also, we have periosteal or juxtacortical chondromas when they occur on the surface of the bone. Chondromas can also arise from the synovial sheath or tendons, or in the soft tissues adjacent to the tendons in the hand and feet in the adults. In such cases, they are referred to as soft tissue or synovial chondromas. Chondromas account for nearly 5% of all bone tumors, in the average or range of 3 to 10%, and nearly 17.5% of benign bone tumors, with the range of 12 to 24%. The age of incidence is 10 to 30%, most frequently diagnosed in childhood to early adulthood.
10 to 30 years, not percent.
Sorry, 10 to 30 years. About 60% of chondromas occur in the small tubular bones of the hand and feet. The next most common sites are the long tubular bones, as the humerus, femur, and tibia. They share histologic features with low-grade chondrosarcoma and are sometimes classified under the umbrella term low-grade chondral serous tumors. The clinical presentation, usually patients with enchondroma are asymptomatic. However, lesions of the hand and feet may present with pain that is due to the pathological fracture. So the diagnosis is usually incidental. But malignant transformation into low-grade chondrosarcoma is associated with pain, which is rare, only accounting for 5% of the cases. The location and distribution in the body, enchondromas are typically located in a central or eccentric position within the medullary cavity of tubular bones. As we said, small tubular bones of the hands and feet are accounting about 60%, and the most common site is the proximal phalanx. Then followed by the large tubular bones as femur, tibia, and humerus, and we have the rare sites as the pelvis, ribs, and scapula. We should know that in this position we should consider chondrosarcoma, especially in the pelvis, as almost all hyaline cartilage tumors of the pelvis are considered malignant based on anatomic location, no matter what the pathology shows, because these tumors will de-differentiate.
And they start benign and then change.
Yes, they de-differentiate. This is the picture that's showing the typical distribution of the enchondromas, that is involving the small tubular bones of the hand and feet, followed by the large tubular bones of the humerus, femur, and tibia. And this picture is showing the distribution of the solitary enchondromas of the hand. As we said, most commonly it's involving the proximal phalanx, constituting for 40 to 50% of all solitary enchondromas of the hand, followed by the metacarpal, constituting 30%, followed by the middle phalanx, constituting 20 to 30%, distal phalanx, constituting 5 to 15%, and finally the carpals, constituting less than 2% of all solitary enchondromas of the hands. How the enchondromas appear on radiograph, CT, and MRI. Enchondromas have a variable appearance, although typically they are small, less than 5 centimeter lytic lesions with non-aggressive feature. I mean, there is narrow zone of transition and sharply defined margin. With or without chondroid calcification, and we have what's known rings and arcs of calcification, often no matrix mineralization. I mean, it's purely lytic in the hands and feet. It may be expansile, more commonly in the hands and feet, and should not grow through the cortex unless there is associated pathological fracture. So most important point, there is no gross bone destruction, no periosteal reaction, no soft tissue mass. The majority of enchondromas more frequently arise in the metaphyseal region, owing presumably to their origin from the growth plate, although they are frequently seen in the diaphysis. They are only rarely seen in the epiphysis, and a cartilaginous lesion in an epiphysis is more likely to be a chondrosarcoma. This is frontal and oblique projection of the left hand that is showing a well-defined lytic lesion seen in the proximal phalanx of the index finger with small cortical disruption that is more obvious in this oblique view here.
You can see it has a typically benign features.
Yes.
It has a well-defined borders, narrow zone of transition, no signs of destruction, no
Yes.
soft tissue component. It's seen mostly in intramedullary, in the center of the bone, not eccentric.
And the most common site.
which is the common site for
Proximal
enchondroma.
phalanx.
It is by far the most common site for enchondroma in the proximal phalanx. Okay,
Yes.
so you should always think of enchondroma in such cases. يعني تقريبا no other differential. Okay.
Yes. This is another radiograph, frontal and oblique projection of the right hand that is showing a well-marginated lucent lesion observed in the distal metaphysis of the fifth metacarpal. The lesion contained calcification in the punctate form, and there is a fracture line that is seen in an oblique
So you can see the
obliquely
fracture line
oriented.
that is little bit displaced,
Yes.
little bit displaced, and you can see the typical calcifications, the chondroid calcifications,
Yes.
tiny dots, white dots. These are typical for chondroid, and you can see intramedullary, well-defined, narrow zone of transition, no destruction, no
But
soft tissue
associated
component,
with
no invasion.
pathological fracture.
It's most likely
Enchondroma. This is another radiograph, frontal and oblique projection of the left hand that demonstrating abnormality in the metaphyseal region of the third proximal phalanx, characterized by non-aggressive lytic lesion, but somewhat expanding the local bone, and there is some discontinuity in this cortical area that may be a pathological fracture. This is frontal, magnified frontal and oblique view of the left foot that is showing defined, slightly expansile, more obvious here, lytic lesion with a narrow zone of transition and scaltanic amorphous calcification that is seen in the proximal phalanx of the second toe. We see some cortical irregularity in the lateral and medial cortical borders that may be pathological fracture. This is an uncontrast CT scan of the distal femur that is showing a large lesion occupying most of the metaphyseal region reaching almost to the proximal diaphyseal region with multiple benign cartilaginous type of calcification, as we said, arc, ring and arc of calcification, yes, narrow zone of transition. We see the cortex not disrupted, not eroded, so it's most likely indicating a benign lesion. On MRI, enchondromas appear as well circumscribed, somewhat lobulated masses. On T1, they are intermediate to low signal in comparison to the muscle. In T1 contrast, enhancement is variable and may be seen both peripherally or in translesional septi. In T2, typically of background of intense high signal, bright signal, it might contain calcification. This is selected image of T1 sagittal, T2 sagittal, T1 axial, and T2 axial of the ankle joint that is showing a well-defined lobulated mass that is occupying the distal tibia, and it returns low signal on T1 and bright signal on T2. As you see, the mass is well defined. There is no cortical disruption, no infiltration of bone cortex or extraosseous spread, no surrounding bony edema. On nuclear medicine, there will be increased uptake on the bone scan, can be seen with enchondromas here, and the proximal phalanx, there is increased uptake. Also, intense uptake occurs with underlying pathological fracture or cortical expansion in small bones. So, the differential diagnosis, the main differential diagnosis is the bone infarction. But we can differentiate it from enchondromas by that it has ill-defined margins, densely sclerotic, serpiginous border, and no endosteal scalloping. The second most is the chondrosarcoma, and this chondrosarcoma may be the sequelae of this enchondroma. But the clinical findings, primarily the pain better, is indicator for the chondrosarcoma than the radiographic findings. It is associated with periosteal reaction. There may be soft tissue mass, and the size is usually more than 4 centimeters. That is suggesting the malignancy. Epidermoid inclusion cyst is the third most common differential diagnosis, but usually there is history of trauma, and during examination we see phalangeal tuft. The other differential is juxtacortical chondroma, but usually it involves the bone surface, can erode underlying cortex, and periosteal new bone formation is associated with juxtacortical chondroma. We have a long list of enchondroma, especially in if the patient is skeletally immature. We have different, for example, non-ossifying fibroma, fibrous cortical defect. In the adult, we have fibrous dysplasia, a long list of differential diagnoses. The associations, two syndromes are associated with multiple enchondromas. We have all-year disease, which is a non-hereditary disease characterized by multiple enchondromatosis, but usually in this condition the age is between 5 to 10 years, and the patient has pain or pathological fracture. We have Maffucci syndrome. It is Maffucci syndrome. It has a familial association, also characterized by multiple enchondromas or chondromatosis. But we can differentiate it by the hemangiomas. It's associated with soft tissue hemangiomas.
See soft tissue?
With phlebolithis, yes.
Calcified phlebolithis.
Yes.
You know there is a hemangioma, and you know this is a Maffucci syndrome.
Yes.
Not pure enchondromatosis. Okay?
Yes, you are right. Nearly 20% of Maffucci may undergo this metaplasia, and they will transform to the malignancy in the future. This is a hazard. Treatment, the majority of enchondromas remain asymptomatic, require no treatment, but pathological fractures are commonly treated by curettage and bone grafting with follow-up x-rays to monitor for healing and recurrence. The recurrence rate is 2 to 15% and may suggest malignancy. If malignant transformation is suspected, it occurs in less than 3% of cases, then the treatment is more aggressive. The complications are pathological fracture and malignant transformation into chondrosarcoma, as we said, in less than 5%. Thank you.
Thank you. Just two words. First of all, chondrosarcoma, it is a low-grade malignancy. يعني مو كلش aggressive, not very aggressive tumor. It's relatively low grade, it grows slowly usually. Second, in any exam, بالpractical life, يعني you have patient, if you have in a board exam, in a whatever exam, never ever comment على CT or MRI of a bony tumor without having X-ray. Never ever. هاي يعني خليها بأذانك. Any CT, any MRI يعطيك يا شفت ماس أو ليجن بالبون رأسا قبل لا تعلق أي شيء. I want X-ray. Okay? Even if you know this is enchondroma or you know this is I don't know what, exostosis, whatever. Okay? لا تحكي ولا كلمة. رأسا I want X-ray. If you don't say I want X-ray حتى لو قلت كلها صح يقول فيها. اوكي هي الفكره انه دي يشوفك راح تطلب اكس راي ولا لا تمام ايه دكتور
nice presentation. But I have a question. When we differentiate all the time between infarct